Welcome to Nephrology Notebook. Today we're reviewing the RENAAL trial, one of the landmark studies that moved diabetic kidney disease care beyond blood pressure control alone. The key question was simple but practice-changing. In patients with type 2 diabetes, albuminuric nephropathy, and impaired kidney function, could Losartan reduce hard kidney outcomes when added to conventional antihypertensive therapy? Let's build the clinical logic from bedside problem to trial evidence. The central takeaway is that Losartan reduced the risk of major kidney outcomes in type 2 diabetes with nephropathy. The benefit was driven by fewer patients reaching doubling of serum creatinine and end-stage renal disease, not by improved survival. Importantly, the effect persisted after adjustment for the small blood pressure difference between groups, so RENAAL helped establish RAAS blockade as kidney protective therapy, not merely antihypertensive therapy. Let's anchor this in Robert, a 61-year-old man with long-standing type 2 diabetes, hypertension, retinopathy, rising creatinine, and severe albuminuria. His blood pressure is not perfect, but the bigger signal is progressive diabetic kidney disease. This is the phenotype RENAAL was built to study. High albuminuria, reduced kidney function, and substantial risk of kidney failure despite usual blood pressure medications. Robert's dilemma is the classic pre-RENAAL problem. We can keep adding medications to lower systemic blood pressure, but diabetic nephropathy is not just a brachial cuff problem. Inside the glomerulus, angiotensin II constricts the efferent arteriole, raises intraglomerular pressure, and promotes protein leak. The clinical question becomes, can we protect the kidney by targeting that local hemodynamic injury? At the time of RENAAL, diabetic nephropathy was already the leading driver of kidney failure. The urgency was not theoretical. Patients with type 2 diabetes were progressing to dialysis in large numbers, and clinicians lacked outcome-proven therapies specifically validated in this population. This background matters because RENAAL was not asking whether Losartan improves a lab number. It was asking whether kidney failure could be delayed. Kidney failure changes everything: quality of life, hospitalization risk, cardiovascular vulnerability, and health system cost. Dialysis can be life-sustaining, but it is also burdensome. For patients like Robert, even delaying the need for dialysis is clinically meaningful. That is why RENAAL focused on hard endpoints: doubling of creatinine, kidney failure requiring dialysis or transplant, and death. The mechanism begins at the glomerulus. In diabetes and hypertension, afferent inflow and efferent outflow become maladapted. Angiotensin II preferentially constricts the efferent arteriole, increasing pressure inside the capillary tuft. That pressure contributes to albumin leak, podocyte stress, and progressive scarring. This is why a drug can protect the kidney, even when the systemic blood pressure difference appears modest. Before RENAAL, ACE inhibitors had strong evidence in type 1 diabetic nephropathy, especially from captopril data. But type 2 diabetes was a different evidence gap. Clinicians were using diuretics, calcium channel blockers, beta blockers, and other agents to meet blood pressure targets. But no therapy had clearly shown kidney outcome benefit in this exact population. RENAAL was designed to close that gap. This is the conceptual leap. Lowering systemic blood pressure is necessary, but it may not fully address glomerular hypertension. RAAS blockade targets the intrarenal mechanism by reducing angiotensin II signaling at the efferent arteriole. In practical terms, RENAAL tested whether kidney protection required more than getting the cuff pressure down. The answer was yes. Mechanism and outcome both mattered. The intervention was Losartan, an angiotensin II receptor blocker, dosed at 50 to 100 milligrams once daily. Patients in both groups still received conventional antihypertensive therapy, but ACE inhibitors and other ARBs were excluded. That design is important. The trial tried to isolate the effect of Losartan on top of usual non-RES blood pressure treatment. Next, we'll look at the receptor target. Losartan blocks the angiotensin II type 1 receptor, or AT1 receptor. That reduces angiotensin II-mediated vasoconstriction, aldosterone signaling, and downstream growth in inflammatory pathways. In the kidney, the clinically relevant effect is reduced efferent arteriolar tone and lower intraglomerular pressure. That explains both the expected fall in proteinuria and the possibility of a small, early creatinine rise. Think of the efferent arteriole as the outflow valve of the glomerulus. When angiotensin II tightens that valve, pressure builds upstream. Losartan relaxes that outflow resistance, lowering intraglomerular pressure. The result is not healing in a literal sense, but reduced mechanical stress and less albumin leak across the filtration barrier. That physiologic effect becomes clinically important when sustained over years. RAAS blockade has predictable trade-offs. Less aldosterone can raise potassium. Efferent arteriolar dilation can lower filtration pressure and produce a mild creatinine increase early after initiation. In the right patient, that small creatinine bump is expected and often acceptable. The key is monitoring. Potassium, creatinine volume status, and interacting medications determine whether therapy is safe to continue. RENAAL asked whether targeted interruption of the renin-angiotensin system with Losartan could delay major kidney outcomes in type 2 diabetes with nephropathy. The hypothesis was not simply better blood pressure equals better kidney outcomes. It was more specific. Blocking angiotensin II signaling might protect the kidney beyond the effect of conventional blood pressure lowering alone. The trial randomized 1,513 patients after a run-in period. One group received Losartan, 50 to 100 milligrams daily, plus conventional antihypertensive therapy. The other received placebo plus the same style of conventional therapy. Follow-up averaged 3.4 years. Blood pressure targets were aggressively pursued in both arms, which made the trial a cleaner test of Losartan's kidney-specific contribution. The population was high-risk and clinically recognizable. Adults 31 to 70 years old with type 2 diabetes, macroalbuminuria, and elevated serum creatinine. The trial excluded type 1 diabetes, non-diabetic kidney disease, and patients with recent major cardiovascular events or prior heart failure. So these results apply best to albuminuric diabetic nephropathy without advanced unstable cardiovascular disease at baseline. Baseline risk was substantial. The average age was about 60. Most patients were already hypertensive and on treatment. Mean creatinine was around 1.9 milligrams per deciliter, and median albuminuria was very high. This was not early microalbuminuria. These were patients already on a trajectory toward kidney failure, which makes the observed reduction in kidney endpoints clinically meaningful. Both groups received intensive background blood pressure treatment, including calcium channel blockers, diuretics, beta blockers, alpha blockers, and centrally acting agents. The end-of-study mean arterial pressures were very close: 95.9 millimeters of mercury with Losartan and 96.8 with placebo. That small difference does not fully explain the renal benefit, although blood pressure may still have contributed modestly. The primary composite endpoint was time to the first of 3 events: doubling of serum creatinine, end-stage renal disease requiring dialysis or transplant, or death from any cause. This endpoint matters because it combines kidney function decline, kidney failure, and survival. But interpretation requires nuance. The overall composite was positive mainly because the kidney components improved, not because mortality changed. Losartan reduced the primary composite endpoint by 16% compared with placebo, with a statistically significant p-value of 0.02. The event curves separated over time, consistent with a disease-modifying kidney effect rather than an immediate symptomatic effect. For clinicians, this is the main evidence signal. Adding Losartan reduced the probability of reaching a major kidney outcome. The kidney components tell the strongest story. Losartan reduced doubling of serum creatinine by 25% and end-stage renal disease by 28%. Death was not significantly different. The authors estimated that the reduction in kidney failure corresponded to an average delay of about 2 years in dialysis or transplantation. So the safer phrasing is not halted kidney failure, but reduced and delayed kidney failure outcomes. Albuminuria fell by an average of 35% with Losartan, while it tended to rise in the placebo group. In diabetic nephropathy, albuminuria is both a risk marker and a contributor to progression. The reduction supports the mechanism: lower intraglomerular pressure and less filtration barrier stress. It does not prove structural reversal, but it strongly supports kidney protective physiology. Cardiovascular results were more mixed. The composite of cardiovascular morbidity and mortality was not significantly reduced. However, first hospitalization for heart failure was reduced by 32%. That is clinically notable, but it should not be overstated as broad cardiovascular protection. Renal's primary legacy is kidney protection, with a specific heart failure hospitalization signal rather than a global cardiovascular mortality benefit. Losartan was generally well tolerated, even in a high-risk CKD population. Overall discontinuation due to adverse events was actually lower with Losartan than placebo. Hyperkalemia-related discontinuation was uncommon but higher with Losartan, 1.1% versus 0.5%. The practical lesson is familiar. RAAS blockade is usually manageable, but potassium and creatinine monitoring are not optional. RENAAL was large, multinational, randomized, double-blind, and placebo-controlled. It enrolled over 1,500 patients and followed them for an average of 3.4 years. The endpoints were clinically meaningful: dialysis, transplant, doubling of creatinine, and death. Background antihypertensive therapy was actively managed, which strengthens confidence that the renal benefit was not simply ordinary blood pressure control. A reasonable critique is that blood pressure was slightly lower in the Losartan group. The investigators addressed this with statistical adjustment, and the kidney benefit remained. Still, the cleanest interpretation is not blood pressure had no role. It is that Losartan's renal benefit exceeded what would be expected from the small blood pressure difference alone. That is the evidence-aware framing. This slide captures the enduring teaching point. Kidney protection is not only about systemic pressure. In diabetic nephropathy, intraglomerular pressure matters. RENAAL showed that Losartan reduced kidney outcomes in this population. It does not by itself prove a universal ARB class effect, but alongside other RAAS blockade trials, it helps shift diabetic kidney disease care toward mechanism-based renal protection. Back to Robert. His rising creatinine and severe albuminuria resemble the renal phenotype. Based on this evidence, Losartan would be a rational kidney protective therapy if no contraindication exists. Start low or standard dose, titrate as tolerated, and monitor creatinine and potassium within about 1 to 2 weeks after initiation or dose increase. A mild creatinine rise may be acceptable. Hyperkalemia or volume depletion requires action. RENAAL helped change the standard. In type 2 diabetes with hypertension and significant albuminuria, therapy should include RAAS blockade unless contraindicated. The modern approach is layered, but the foundation remains the same principle. Identify albuminuric kidney disease early, use therapies that reduce progression risk, and titrate treatment toward kidney protection, not just a lower blood pressure number. RENAAL's legacy is that Losartan reduced major kidney outcomes in type 2 diabetic nephropathy and helped establish RAAS blockade as renoprotective therapy. The precise message is not that Losartan cures the filtration barrier, but that it lowers proteinuria, reduces intraglomerular stress, and delays kidney failure outcomes. Thanks for watching Nephrology Notebook. Like, subscribe, and follow for more landmark nephrology trial breakdowns.